Today we're going to talk about asthma. Asthma is a chronic inflammatory disorder of the airways that affects 16 million Americans, leading to an unpredictable clinical course with episodes of control as well as acute exacerbations, leading to recurrent chest tightness, cough, dyspnea, and wheezing. Asthma occurs more commonly in obese patients or those with genetic predispositions. Numerous genes have been identified that affect immune responses, including the effect on smooth muscle and airway reactivity. As adults, women are 66% more likely than men to have asthma, and some people have a genetic predisposition to develop an allergic response to common allergens, known as atopy. Environmental factors can also play a role in development of asthma, as there's higher rates of asthma in industrialized areas due to the increased airborne pollutants, or due to the hygiene hypothesis, which states that the immune system must be educated, aka exposed, to allergens or irritants at a young age in order to learn the proper response. Next, we're going to talk about the pathophysiology of asthma. The process begins with a trigger, which may be an allergen, such as pollen, an irritant, such as fumes, an infection, whether it be bacterial, viral, or for some people, exercise can induce asthma. No matter the trigger, it leads to an immune activation and production of IgE. This IgE binds and reacts with mast cells in the lungs. Causing them to release a number of inflammatory mediators. Including histamine, slow-reacting substance of anaphylaxis, eosinophilic chemotactic factor, and bradykinin. These mediators have a combined effect on the lungs, leading to edema or inflammation in the bronchioles, increased mucus production clogging the bronchioles, and bronchospasm caused by constriction of the bronchial or smooth muscles. These effects are what cause the increased airway resistance, making it difficult for asthma sufferers to breathe, causing the symptoms that we discussed before, including cough, wheezing, chest tightness, and dyspnea. There's a few diagnostic tests that can be completed in order to diagnose asthma, mostly clinical manifestations and history and physical, but you can also do pulmonary function tests and peak expiratory flow. In treatment of asthma, the goal is to achieve and maintain control of the disease. Control is identified as decreased symptoms, less nighttime awakenings, decreased interferences with normal activity, and less use of medications. Medications used in the treatment of asthma typically include a controller medication, such as an inhaled corticosteroid, for example, Flovent. These can affect the edema process and decrease inflammation in the bronchioles. Sufferers of asthma tend to need a rescue medication as well to be used during an acute exacerbation. This could be a short-acting beta-2 adrenergic agonist, or a SABA, which stimulates the beta-adrenergic receptors, causing bronchodilation and combating the bronchospasm that occurs with asthma. These can have an onset within minutes and last 4 to 6 hours, but they must be used in caution in patients with cardiac disorders due to a risk of arrhythmias, tachycardia, and increased blood pressure. The controller medications can take a couple weeks to reach peak effectiveness, and patients should be educated to that fact. The references for this presentation are posted below. Thank you for watching.